Good morning, good afternoon, good evening, depending on where you are at this point. Welcome to the second remote international session. And we are here going to discuss the scleral lens and disease. And IFSLR has a mission, and that is to advance the discipline of scleral lens prescribing through the coordinated effort of evidence-based research and clinical practice. And that's what we are. And today, we are going to focus on scleral lenses and ocular disease. After all, here's our thought, after all, most scleral lens patients have some visual and ocular compromise, and therefore we need to consider what the lens will do to their situation. We are going to address if the scleral lens, after all, is the optimal option. Is the scleral lens compromising corneal health? Are there situations when the scleral lens is definitely contraindicated? We must consider the benefits versus the risk. These are sort of topics I hope we will touch upon with our invited speakers and panelists. And remember, we are looking at the evidence and not anecdotal statements. We want to know what is it we really do know. And I should say that the speakers and panelists are here because of their contributions in the peer-reviewed literature. We could not do this without the generous support of Bausch and Lomb and Cooper Vision. And today we have the pleasure of introducing to you Patrick Marsalek, Senior Director of the Specialty Vision Products at Bausch and Lomb. And he has a couple of comments to you who listen in or tune in on this. Welcome, Patrick. You have the word.
Thank you, Jan. It's great to be here, and it is just a few words. I'll get you guys into the wonderful meat of what's going to be covered today. But no, all I wanted to share was first is to truly acknowledge the passion and commitment I see in this group. You know, those that spend the time in the lab doing the research and sharing the results, and those of you taking a weekend, morning, or wherever you are in the world, afternoon, evening, as Jean said, to increase your knowledge and expertise with these wonderful lenses that really do so much to improve patients' lives. And, you know, for those reasons, I'm certainly, Bausch & Lomb is proud to be partners with the IFSLR. I clearly am not medically trained, but even from that standpoint, I assure you, a lot of this goes over my head, but I even come away from these meetings with a better understanding than before I attend the sessions. And that's really what it's all about. I think at every level, you know, what do you take away from it? Where were you before and after? And I find these sessions to be invigorating. I absolutely love the panelists, the research, the sharing. You guys do such a wonderful job. And so just very proud to be partnering and working with you all. Quickly, you know, I obviously don't have research to share, so that's why this will be very brief, but I would like to let you know at least where Bausch & Lomb's efforts are focused on in the near future. And that is with, if many of you, hopefully many of you saw Dr. Jellica's presentation during GSLS where he talked about Zen-Lens, but more importantly, using technology to unlock features of the scleral lens, which works across many of the scleral lens designs. You know, the integration and usage of these technologies are becoming a more and more critical aspect of fitting sclerals. And at B&O, we believe the instrumentated fitting and eventually designs are the future of the custom lens space. And so we have a strong belief that, these technologies will elevate eye care professionals' proficiency and ability to have greater success with patients, and obviously have, even more successful patient outcomes. So we are certainly open and interested in the research and any discussion you might want to have on that topic for sure. So I just want to make sure everyone has line of sight to that. And like I said, we're open to any conversation. So that's really all I wanted to say and share. And I do appreciate the time. And so again, I just want to thank you all for what you do day in and day out with your patients, especially during these unique times. And with that, I hope you enjoy this wonderful program. So thank you.
Thank you, Patrick.
One comment I'll make, it looks like, I like when people put where they're from in the chat. It's kind of fun for us to see. I see a few of you did already. We've got people from Poland, Ashley's up early in California, South America, Ecuador. So
right.
do
Truly
put that
international.
Yeah, I love it. All right, over to you.
All right, we are going to start with short speeches by people we selected because of their peer-reviewed publications. And first in line is Dan Fuller, who is a graduate from Ohio State University. And he started his career by serving in a hospital setting at the U.S. Navy, and then followed 17 years in private practice, running his own, among other things. And currently, Dr. Fuller is a professor at the Southern College of Optometry, and he is a chief of the cornea contact lens refractive surgery and a clinic, and he is chief of residents at the college as well. He is a secretary of the Scleral Lens Education Society, and he has published extensively, and he is ready to take over from me now. Welcome, Dan. Thank you for joining this effort.
Thank you, Jan and Maria, for the invitation. I appreciate the opportunity to address the group, and really am impressed with what I've heard so far last time with the presentations on interocular pressures and scleral lenses. So I hope we can add to that significantly today. So the presentation I'm going to give you today is based on an article that I had written with one of my star residents in optometry and vision science in the September 2020 edition, which is devoted to scleral lenses. And it's basically about the safety and efficacy of scleral lenses. As we went through the literature, there hadn't been much that was written since Tan's early work in the closing days of PMMA lenses and dawning days of GP lenses. And in fact, our host, Jan and Maria, did a nice job of kind of summarizing some of the gaps in the literature with an article that they had presented. And there had been a smattering of presentations in the literature across the world on individual case series or case reports. But I wanted to go a little bit deeper and see what we were doing in our clinic at SCO and see if we could add significantly to that discussion as well. So that was basically the purpose of what I was undertaking. And we actually did two studies. This is the only one we've had published so far, but we looked at the safety and efficacy in both keratoconus patients, but also in post-surgical eyes. The post-surgical eyes part was presented first, actually, in a poster session at the Academy a few years ago. And this was kind of the follow-on, and it was a lot easier to kind of compile this information because of the more continuity of the underlying morbidities. But as we know, there's over 70,000 scleral lens wearers estimated right now in the US. And the indications overwhelmingly, as we know from the SCOPE study and other studies, the main indication has been corneal ectasias, and among that, keratoconus is certainly the most common. But you can see the other reasons why we're fitting scleral lenses down below there, and certainly post-surgical causes would be second, and ocular surface disease, aphakia, and a growing part of the market are just general refractive errors like high cylinders. So what I did is with my residents, we went back over a 5-year period, as you can see there, from 2013 to 2018, and did a retrospective study. Now, with apologies to Loretta, certainly not the best of epidemiological studies, prospective studies, cohort studies, that sort of thing would provide us with a much better longitudinal look at these things in a prospective fashion, and give us a little bit stronger evidence on what we're finding. But nonetheless, I think it's helpful to kind of look at what's going on in a center where we see largely secondary, tertiary care type referrals from the ophthalmological community in the area, and really a 3-state area, as well as the local ODs. So what we did was we included anyone that was wearing scleral lenses, regardless of age, sex, or pre-existing morbidity, that were wearing scleral lens designs. And what we did was we wanted them to have been successful in wearing their lenses for over a year's period. The thought being there is that we were looking for sort of a medium-term look at how they do, and not just how they do in the initial fitting period. Looking at the initial fitting period, you can imagine that you may possibly have more adverse events that occur, and some of those folks would be weeded out perhaps on the front end. So these are the folks that have kind of gotten through all those hurdles and been funneled into kind of a medium-term success rate. And the exclusion criteria were anybody that had corneal surgeries, dystrophies, degenerations, or traumas as well. So how did we do that? Well, we had about 385 subjects that we screened. About 95% of those we excluded for not having had success over a 1-year period. That left us with 86 subjects and 157 eyes that met the criteria. The females outnumbered the males, as they do in optometry school, and they were fit. 15 of them were fit in the single eye, and 71 of them were fit bilaterally. And that's not unexpected, of course, with keratoconus being sometimes an exquisitely asymmetric disease. The mean age of fitting was in the 34.8 year range, and you can see the age range there from 14 to 64 years. So obviously reflecting the onset in the early decades of life. The time to diagnosis, which I found somewhat interesting, was 54% of the cohort had gone into a scleral lens in less than 5 years, roughly 17% in the 5 to 10 year range, and another 29% had been diagnosed with keratoconus 10 years prior to going into a scleral lens. So I think that's kind of interesting, and it'd be, I think, instructive to follow that over time to see if that indicates a trend that we're maybe adopting scleral lens sooner rather than later, since this is now a little bit of an age data set looking back to 2013, 2018. The mean age, or the mean K max with these folks were 61.4 diopters. So you can see that we're really dealing with some folks that are more on the moderate to severe end. And the mean overall diameter of the lenses that were fit, and it was a variety of lenses, not just a particular lens. And there had been a number of studies in the literature that looked at one particular design followed post-surgically or in a particular series of lenses that were fit. And so we looked at what we had to kind of reflect a more generalizable result of a variety of lenses that we fit. And interestingly, about 70% of them had toric scleral zones. So here you can see, again, the frequency of severity. We use the KSS scale. There are certainly other scales that are out there. This was a scale that Tim McMahon and others had used in the CLEX study, and was handy for our purposes of looking at that. There are other ones that do a nice job of also incorporating a number of other data points or attributes of the disease over time. What's not included in some of these things are really things that we talked about in the GSLS meeting, which are wavefront distortions and not just logmar acuities. And we know that those may be more important to the patients. But it's another way of looking at the degree of severity that we saw in the patient base that we were fitting. And here's really the first of the outcomes, looking at safety. And we sort of broke them up, if you can, if we can see this with my arrow here, into physiological adverse events and lens-related adverse events. So 9.6% of the eyes that we looked at had adverse physiological events. The largest, most prevalent adverse event that we observed were corneal high drops. And again, that's a reflection of some of the severity of the cases, I suspect, that we were looking at. Interestingly, there were things like pinguiculitis that actually occurred. And so that may be an indicator there that we should be thinking about notching and vaulting more. Corneal infiltrative events, both asymptomatic and symptomatic, contact lens associated red eyes, abrasions, flectennulosis, which is, I think, probably an outlier, and microbial keratitis, which is arguably the most severe potential adverse event that we saw, really only occurred in one case that we saw. And, you know, again, because of some limitations we'll talk about later, it makes it difficult to extrapolate this finding, but it is certainly a low frequency of occurrence within our data set. And I think probably most interesting and not surprising to those of us that are fitting a lot of these lenses, the most common adverse events tend to be lens related, and that occurred in over half of the eyes that we saw. Broken lenses, I don't know if it's just our folks are maybe more clumsy or not, but it would be interesting to compare against other studies going forward as to whether this is a very common event or not. Certainly goes to the expense of the lenses and replacements, and of interest to industry in terms of warranties and replacement policies and how we can help these patients that have to invest so much in the lenses. And then, you know, we can put together a few things like lens deposits, reservoir clouding, and pore wetting, or we can tease them out separately since they likely have all different causes for these things. And you can see the frequencies there in the intolerance of the lenses and handling issues. So, and pore wettability, it seems like we're gaining on that and doing a little bit better job these days of addressing those things. So I found those to be interesting, and those were our safety outcomes that we were looking at. When we look at how we manage those problems, again, the most common way of managing the adverse events were managing them through refitting of the lenses. And this is because of the frequency of folks that went on to progression and resulting in a refit. But you can see re-educating the patient on lens care was also very high on the list in terms of the interventions that were involved. And so every time you bring the patient in, it's important to review their care, their handling, how they're manipulating the lenses, have them demonstrate the care of the lenses to you, or how they insert them, how they remove them, how they clean them. And you may be able to reduce some of the problems like broken lenses and lens deposits, that sort of thing. Interestingly, medical treatments, rather low on the list. And again, a reflection of the fact that from a safety standpoint, those adverse events are relatively low frequency. If we look at efficacy, we looked at best corrected distance logmar acuity as being the best measure of efficacy. And here we compared on the left spectacle lens wear against the scleral lens wear. And you can see a very statistically significant difference in improvement. Again, a testament to what we already know and supported by the literature that scleral lenses really do improve the quality of vision as well as reports on quality of life. On the right-hand side, what we're looking at there is how did these folks do in terms of best corrected vision after an adverse event? And there were significant reductions noted. What I don't have on there are the outliers. I kind of removed those just to clean up the slide, but there were some folks that had dropped a hand motion, one person, individual that had dropped a hand motion. That was the person that progressed on to high drops during the course of the 5-year period that was observed. So not surprisingly there. And that person went on to penetrating keratoplasty, as is often the case and restored full function to their vision. So even with that adverse event that was not necessarily specifically lens related, since we know as many as 10, maybe 15% of the folks progress to eye drops anyway, it was not too surprising they did better after a PK. So limitations in the study, we've already mentioned some. The retrospective design, we're looking at a clinic where I have in any one semester maybe 11 to 14 faculty members working under me, and we have a new crop of fourth years that have their hands in the mix as well every 12 to 15 weeks. So we've got a variety of different approaches and things going on. And as much as we strive for consistent record keeping, there is some variation there, and not just skill of observation, but also in documentation. So there is variability. Adverse events occurring in the first year, as I mentioned, were not recorded and probably warrant a study in and of themselves to really hone in on how do we get those people to a category that we consider successful. And the design does not allow a comparison to other studies on prevalence and incidence of, say, things like microbial keratitis, because of not following things out long enough in a prospective way in a cohort to be able to calculate person years or that sort of thing. But the main takeaway that I'll leave you with here is that our findings were consistent with the findings with a great many other groups, that scleral lenses are both safe and effective over the long term, but more work is really needed to really put a finer point on the epidemiology and the mechanisms that underlie the adverse events specifically and how to mitigate those. So I'll leave you with that, and thank you for the opportunity to present to you.
Thank you, Dr. Fuller. This was a great study, great presentation, and I'm sure we have a few things to discuss that. I think Dr. Walker is ready to jump in.
I was sitting here talking to him while you were presenting, and I just had a couple of comments, and then we'll let Lynette share hers. And I think it will be interesting, or Loretta rather, because Loretta's going to talk about a couple of really interesting cases too. And I think it would be good to go back after we listen to her and talk a little bit about the high drops. And I was asking Jan if that was a normal incidence for high drops, and he sort of said maybe a little bit high. And I've always kind of been curious with keratoconus, you know, does removing the lens, that suction force of removing the lens, have any thing to do, and you know, or was it going to happen anyways, and so we don't but I think it's just a worthy thing to discuss. But I also just want to thank you for this type of paper, because one thing that I always, you know, it's so important to be able to communicate with other doctors and other specialists. And the way we can really do that is by being supported by the peer-reviewed literature. I think it's things that we all see anecdotally in the clinic. Oh yeah, you know, vision's great. Most of our keratoconus patients like these lenses better, but to be able to point to peer-reviewed literature when we're, you know, everything from discussing with colleagues to getting grant funding and things like that. I write grants, I know, for keratoconus, so it's nice that people are always asking, well, how do you know, is it proven that it's better? And so I thank you for that. And I also just want to remind people, and there's actually a question here we'll ask you, Dan, but just reminding everybody to put questions into the chat or into the Q&A, and we'll go to them. So I have one question for you, Dr. Fuller. When you're monitoring keratoconus progression in a current scleral lens wear, this is a good question. How long do you have them out of wear prior to scan? So I assume that means like how long after you take the lens off do you do your topography to monitor for progression?
Yeah, so in kind of embedded in that question too, I think, is how often do you see these patients back? And it really has to be individualized ultimately to each patient's underlying problems, and not all of them are lens related. As you can see, some of them are compliance and other issues, but when we're talking about that basket full of patients that have progression, we generally take the scleral lens off after doing all the preliminary chair skills and doing the over refraction, and then we move them over and do the Pentacam and do the comparison plots there at that point. So it's probably no longer than 5 or 10 minutes after lens removal before we do it.
All right, thank you very much. We are now moving on, and it's my pleasure to introduce to everybody Dr. Loretta Szczotka-Flynn. She's a tenured professor at the Case Western Reserve University, and there at the Department of Ophthalmology and Visual Sciences. And she is a OD and PhD from Ohio State, another one from Ohio State. And she earned a PhD in epidemiology at the Case Western Reserve University. Dr. Szczotka is also a associate editor for Eye and Contact Lens, a peer-reviewed impact-factored journal, and it's one of two journals dedicated to contact lenses and anterior eye. Dr. Szczotka has been funded in the past by NEI, National Eye Institute. She has published many papers, and her productivity has been recognized in a number of awards, and that includes Young Optometrist of the Year. She's telling me that was just the other year. And she is also the recipient of Donald Korb Award, and she was also listed as one of 30 most influential international contact lens practitioners in the past 30 years. All right, I welcome you, and the word is yours now, Loretta.
Thank you.
Really quick before you start, go up to your display settings because it's in presenter view right now. Yeah, and it should, there you go.
Hit that.
I think so. Yep, there you go. All right, now I'll let you
Okay. Thank you. Sorry about that. Okay, everybody. Thank you, Jan and Maria, for inviting me. And I'm going to be presenting a paper about a case series of only 3 patients. So Dan, I mean, I have to say that your study was far better powered, retrospective study of 157 eyes. This is just 3 patients. But it actually is one of the first stepping stones of peer-reviewed evidence, a case series that can give us hints into what might be going on. So I do have to give credit to my co-authors, in particular, Sophia Murillo, who's a medical student and aspiring to match in ophthalmology, which I hope she finds out really soon. Aisha was one of our residents. She's now, I believe, in private practice, and Jonathan Lass, who is a long-term colleague of mine and previous chairman of our department. So basically, I'm going to be talking about 3 patients that I've treated that had acute corneal edema years after penetrating keratoplasty for keratoconus, all wearing scleral lenses. So just a brief overview that penetrating keratoplasty is actually still the leading type of transplant in keratoconus. It still exceeds lamellar surgery, and it's not the leading corneal transplant procedure because endothelial keratoplasties for other conditions have surpassed it. But for keratoconus, it's actually still the leading procedure with over 17,000 PKs done in 2019. And late graft failure, so you have acute, you have rejection-based failure, and then kind of late endothelial decompensation is actually the leading cause of graft failure after PK. Now, acute hydrops after PK for keratoconus has actually been reported in 3 separate peer-reviewed articles that I found, which I was surprised to hear about. And the kind of telltale sign of acute hydrops after PK for keratoconus is that you have a break in decimase that you may not always be able to visualize, but that this edema that rapidly develops crosses the graft-host interface. So it's different than kind of acute corneal edema that sometimes is associated with an acute rejection that would only be in the donor cornea. It doesn't cross over usually into the host cornea. So that's kind of a telltale sign to look for as you're examining your patients. So the three cases I'm going to present, you know, you were just talking about incidence, Maria, of high drops. Well, we went through all of our cases, and since 2014, I personally had fit 66 PKs with scleral lenses, and this represents, you know, 3 of them. So it's about 4.5% of my personal patients. These are PK patients fit with scleral lenses. About 4.5% proceeded to this acute corneal edema. So here's case 1. It's a female who had a corneal transplant 35 years ago for keratoconus, and basically developed acute corneal edema straddling the graft-host interface 3 days after getting the scleral lens. And I think this is the patient that really made me think. She had been wearing small corneal lenses I've been treating her for 28 years, tells you how long I've been there. And she was doing just fine, except literally those little corneal RGPs were hanging by a thread, hanging by her upper lid, because you can see her inferior temporal cornea was so ectatic and so steep, and it was just barely hanging on beneath that upper lid. It was time to make a change. She was not functioning very well at all. She was an attorney, needed to see well. And so we decided to refit her into a scleral lens, and you can see kind of the parameters of the scleral lens. You can appreciate how steep it had to be with this over, you know, 60, 50 micron sagittal depth here. You can see her ectasia here in the inferior temporal cornea and how thin she's getting, whether or not we believe these thickness measurements. She was getting really thin in that outside the graft-host interface. She did have a central cell count 6 months prior of 590, which tells us that, you know, we know the cell count in these old grafts is low. They're typically below 600, and we can have a discussion about that. But centrally, it was 590. We also know that peripherally now, cell counts are actually lower than the central cell count that we're normally measuring. And that's because the endothelium continually migrates from the center to the periphery to kind of fill in that gap. So when the wound is made and there's no endothelial cells there, they just kind of have to migrate to that peripheral area. So it's actually quite dramatic when you have the opportunity to measure peripheral endothelial cell density. It's probably much lower in this area. But you can see the acute corneal edema here. I highlighted it. It did go onto the host because the graft kind of ends right about here. There were macrocysts within the graft, and everything else was microcystic edema. And you can also appreciate this sudden demarcation line when everything else on the other side of this area is clear. And in particular, there were no keratic precipitates. There was really no anterior chamber reaction. The patient was in some pain, but this was not signaling an acute rejection episode, which many confuse it to be. She was treated as a rejection at first with steroids, watched, and this just didn't clear, and she needed a regraft. Case 2, somewhat similar, sudden onset edema here. It's a 35-year-old graft for keratoconus, and this is 4 months after dispensing a scleral lens for the first time in the left eye. This patient did have LASIK 3 years prior, LASIK on top of the graft, because he was really kind of contact lens intolerant, and all other lenses, piggybacks, hybrids, and corneals were unsuccessful. So he went for LASIK, which was also unsuccessful, ultimately needing the scleral lens, and wore it for 4 months. Again, you can see his topography here where he does have ectasia in this inferior area. The other thing is that these high drops like episodes that I'm describing always occur in the area of ectasia. So that's a point to make note of. You can see this, again, sudden onset edema, sharp demarcation line, no KP, no anterior chamber reaction. And also it does go on to the host here on the other side of the graft. And if you can appreciate on this anterior segment OCT, here's the scleral lens. And I'm not sure if you can appreciate this shelf-like drop off here where the host cornea just is extremely thin, right where my cursor is showing. So this is really the area of ectasia, probably somewhere around here on the topography map, where he ultimately, we think the break occurred and he had this acute onset edema. Last case, this is a 33-year-old PK for keratoconus, but she wore her scleral lens now for 9 years. She actually had a decent central endothelial cell count, but again, you see acute corneal edema in the area of ectasia. In this case, it's very unusual for the ectasia to be superior. So this is her left eye, superior nasal area, where you can see she had extreme steepening, thinning, and that's the exact same area where she had this kind of acute episode. Otherwise, it was similar, again, edema going onto the host cornea. So just a little bit of a discussion about what others have reported in the literature about sclerals on top of PKs. And all the literature that talked about edema really talked about edema due to low endothelial cell density and kind of the normal endothelial decompensation that we think about with these graphs. So for example, Severinsky had a small case series of PK eyes fit with scleral lenses, and they developed transient edema, which was attributed to low endothelial cell count, and it was reversible. Guillain described a case series of PK eyes wearing mini sclerals that had transient edema, but that diminished after 20 minutes of lens discontinuation. Gwynn reported 3 post-PK eyes that developed macrocysts within edema, and again, they resolved within lens discontinuation. And Scher reported kind of treatment failures with the PROS device, with this edema occurring 1 to 2 hours after wearing the device. So we see that all the time, and we can manage that, but that's not what my cases represented, okay? My cases did not represent this kind of slow, smoldering, low endothelial cell pump that isn't able to keep up. What our case series represented was this sudden onset, rapid stromal edema that must have really just occurred from a break or detachment in Decimase, in which case we can argue whether or not Decimase reforms in that wound. But what happens in these transplant cases is because this always occurs at the graft-host interface, we're probably not going to be able to visualize any kind of a split. So we didn't have any anterior segment OCT. We couldn't actually see this break. But because it occurs in the wound, you're probably not going to see it. And because it goes onto the host and in the donor tissue, it really tells us that this is an unstable area on both sides of the wound, suggestive of this intense, stress that is occurring in the weakest part of the ectatic cornea. So in over my years of specialty lens care in this practice, I've never seen this occur in PK eyes that did not wear scleral lenses, even though I definitely have many cases of really advanced ectasia that are not wearing sclerals, and I haven't ever seen it. So there's probably something about the mechanical, putting it in, taking it out, using the plungers, the negative pressures, and or in my first case that only wore her lens for 3 days, she was very inexperienced with the big scleral lenses and felt very clumsy. And since it occurred so soon after that, we really think that there must have been some association. Of course, just ongoing hypoxic stress on top of a cell count that is extremely probably low in this area could have also precipitated just a complete split and breakdown in that area as well. But I'm more of the assumption that this was a mechanical blunt-like trauma episode that basically split the posterior cornea in that manner. I think that was my last slide. So I'd be happy to discuss things with you further.
Thank you, Loretta. Great paper. We can learn a lot from that. Just so we can have a good discussion in the end, I would like to go straight on to our next speaker from Canada, Vishakha Thakrar. And she graduated from Ohio State, so we have a clean sweep from Ohio State College of Optometry. 3 speakers are all from there. And Dr. Thakrar followed the OD with a 1-year fellowship at NICO in Boston, and with stints at Mass Eye and Ear at the Harvard School. And she is currently running her own specialty contact lens practice in Toronto. The word is yours, Dr. Thakrar.
Thank you, Jan and Maria, for inviting me. Can everybody, I'm hoping, I'm running it off Maria, so I'm going to keep cueing her to advance the slides. But it's a great segue from what Loretta was talking about, going into corneal edema with my particular patients, because it's obviously a different disease process, but we are discussing what we saw clinically with respect to corneal edema and scleral lenses forming edema. So let's talk a little bit about herpes eye disease. When it comes to the patients that we see in clinic, it's not the patients that are acute so much that we're seeing. We're seeing the patients with stromal keratitis and have really turned into scarring, vascularization, possible necrosis. Maria, do you mind advancing? And then even endotheliitis. So as you can see from this particular slide, we have, a circular pattern of endotheliitis with overlying stromal edema. Now, these are the patients, once they have become quiescent and dormant, these are the people with reduced vision, go ahead and advance the slide, who have irregular astigmatism and that corneal scarring that so badly need vision correction with specialty contact lenses. And with the popularity of scleral lenses growing, many of us are fitting these patients in scleral lenses versus RGPs. Go ahead, Maria. So what we specifically did is take 4 of my HSV and zoster patients. We did a retrospective chart review, and all of these patients had stromal scarring and presented for scleral lens fitting. They were between the ages of 51 and 73, and they were on prophylactic antiviral systemic therapy and topical steroids. 2 of the patients were in fact PKP patients. One had a chemical injury, the second had keratoconus. Endothelial cell counts were attempted for the PKP patients, but I wasn't able to get good data on that. And that I find happens often. And as an aside, I am in clinical practice now. I've spent part of my career in hospitals, and it was much easier to get cell counts when you are in an academic setting than when you're referring back to ophthalmology or back to a hospital to get specular microscopy. So it happens often that we have to commence fitting without really knowing the endothelial cell counts. For all of these patients, the IOPs were normal. So this is a couple of the topographies of the patients that I did fit. Go ahead and advance. And I want to just give you a little bit of information on the lenses that we fit. So, as you know, the patients were fit in scleral lenses. The central corneal clearance on average, and I really did summarize this rather than doing case by case, although the cases are quite different. They were between 200 to 250 microns for all patients. The center thickness did vary. On the thinner end, the lens was 0.25. There were a couple that were in the 0.4 range, and there was one that was high plus in the 0.58 millimeter range. And we'll discuss that a little bit as we go on. Lens materials consisted of Boston XO2 for 3 out of the 4 patients and Boston XO for 1 of them. So let's discuss the corneal edema a little bit. So all of these patients developed corneal edema between 1 week and 5 months after fitting. Now, as an aside, I have been fitting scleral lenses on herpetic eye disease for 20 years. So it was really interesting to have 4 patients present like this in a period of 1 to 2 years. One of the patients that developed corneal edema was one of the graft patients. So it was very interesting. As an aside, I want to just give you the case behind it. So she had done really well in scleral lenses. She was referred for conjunctival resection back to the corneal specialist. And the reason I wanted to do that was because the chalasis, the tissue was actually extending into the grafted tissue. And I wasn't comfortable with that. I tried to refit it and was unable to get rid of that tissue. So I thought, let's try conjunctival resection to potentially and ironically take care of that graft. Upon resection, and the ophthalmologist was actually tapering the steroids. She was on Predforte for about 10 years, 15 years. And then the ophthalmologist tapered her down to Lotemax. Shortly after the taper, she came back to see me, and I put the scleral lens, the same scleral lens that I had originally fit her with, back on just to see how that lens was fitting. And very, very rapidly, her cornea erupted with epithelial and stromal edema. So at that time, I did treat her as a herpetic reactivation. So I increased the antiviral therapy, I increased the steroids. I sent her back to the corneal specialist, and the corneal specialist did agree that by doing this taper, she felt that that in fact was the trigger for this, very advanced corneal edema and reactivation of the infection itself. But it is interesting to me that it looked calm prior to putting that scleral lens on the eye. So in my opinion, the scleral lens did in fact break the camel's back, so to speak, in terms of causing that corneal edema. The next patient, sorry, can you go back? Sorry, Maria. The next patient really developed corneal edema after 1 week of dispense of the scleral lens, so we'll discuss that. And 2 of the patients developed corneal edema after about 4 to 5 months of wear. So why, go ahead now, Maria. I wish I could control it. So really, I mean, these cases are quite different. And I could talk probably for a full hour on the differences between these cases. So I decided to just summarize it. So let's look at the differential diagnosis for corneal edema in post-herpetic patients. Go ahead, Maria. So reactivation of the herpetic disease is a very obvious one. It definitely happened in one of the patients. When you think about reactivation and why that particular patient failed, we have to go back to not just the stromal edema, we have to go back to the endotheliitis itself. When the endothelium is that compromised and they have continuous or even repetitive recurrences of endotheliitis, what we're essentially doing is, what is actually happening is further compromise of those precious endothelial cells. And so with that particular patient, when I attempted the refit and her cornea failed, it was interesting. She was so highly motivated to wear scleral lenses that she asked the ophthalmologist if she could have a DSEC in order to return to scleral lens wear. And so that's exactly what happened, is that the corneal specialist did the DSEC. After she was ready to be refit, she returned to clinic and has been in scleral lenses for the past 5 to 6 years. But I think the more obvious thing that we need to look at when it comes to patients with any kind of endothelium compromise is corneal hypoxia. So we have to, we're so attuned, as Loretta said, to paying attention to the corneal endothelial cells for PK patients. But I think that in general, we have to expand that and look at patients whose endothelium can be compromised by any sort of disease. And viral keratitis is up on that list, specifically herpetic keratitis. So, when I put lenses on eyes, just the very presence of a scleral lens can deprive the eye of oxygen or even introduce a foreign body to the eye in the state of a contact lens. But things like lens thickness, post-lens tear film, how tight that lens is fit, I think is really critical for clinicians to look at to optimize the success of these patients. But it really truly comes down to endothelium. So remember, the age of these patients were between 51 and 73 years old, right? So it is an older group of patients. One of them had glaucoma. It was under control and his IOP was normal, in the normal range when I commenced fitting, but that's something to consider as well. 2 of the patients were PK patients. So with those penetrating keratoplastic patients, we know that there's a very rapid decrease in endothelial cell count as we go. And of course, the previous and recurrent herpetic endotheliitis that had been occurring with all of these patients, that I think that really did introduce them to compromise. When we put that scleral lens on, some of these patients just could not tolerate that. So the big clinical take home to this is make sure that we are watching the endothelium prior to fitting these patients. And I would also, I think back to, all these years that I have been fitting lenses, many of the patients that I've fit successfully were RGP patients. So it's just really something to consider when we are fitting herpetic patients. Are we going to fit a scleral, or was RGP a better solution for these patients? So moving forward, clinical pearls that I wanted to give to all of my clinician colleagues out there is maybe start with endothelial cell counts before fitting herpetic patients. Look at the frequency of recurrence. Say a patient recurs once a year, they shouldn't be in scleral lenses. In fact, you should question whether they should even be in RGPs. But I would lean more towards the RGP RGP lens. One thing I wish I had done when I'd seen these patients is take baseline OCTs or pachymetries. When patients come in, there's several patients, even with epithelial edema, that come in that, we're a little bit concerned about, is this patient going to tolerate a scleral lens? And I think those OCTs or baseline packs will help us monitor their wear as they move forward. One thing I've done several times clinically for patients that I was a bit concerned about is doing what's called a type of stress test. I've kept them close to the office and put either a trial lens on or their initial fitting lens on, and had them wear it for anywhere from 4 to 6 hours, had them return and see, is there any compromise to the cornea? Is there corneal edema, epithelial or stromal? Keeping lens thickness and tear film low so that we can optimize oxygen, checking IOP, making sure the lens is not too tight. And the other thing that I do as well is, there's situations where a patient will say to you, look, I need to wear this scleral lens to drive, or I need to wear the scleral lens for a couple of hours a day. Is there any way you will allow me to do that? And if the patient can safely get through that period of time, then that is something that we are still able to do to give them that opportunity to live. So I supplement with Mura 128, and many of these patients are already on topical steroids to help with reducing corneal edema. And finally, fenestrating the lens, which I don't do very often. I read a contact lens spectrum article that Lynette had published stating how fenestrating the lens had actually allowed a patient to wear the lens much longer, which I think is really impactful for these types of patients and something that we can use as a problem-solving tool. So again, just to reiterate, looking at the corneal endothelium will really help improve success and at least determine whether these patients should be in scleral lenses. Thank you.
Thank you very much. That was a very thought-provoking, interesting presentation. We have now a few minutes to discuss things. I'm just going to make a couple of brief points, and then we're going to spend the rest of the time to address questions. Dan Fuller mentioned that a lot of, or a number, 26% of his patients had aphakia. Just to remind everybody, when you don't have a lens, intraocular lens implanted, you must prescribe a UV blocker in the scleral lens. And also want to point out that we discussed here a number of people who had penetrating lamellar keratoplasty. And I just want to remind people that Bill Byrne up in Minnesota published a number of papers, excellent papers, and they showed that keratoplastic patients have a cell loss that is twice at the rate of a normal cornea. So we need to factor that in, that these people will have endothelial problems. And one final comment to what Loretta said was that the leak of fluid into the cornea seemed to occur somewhere in the interface. And when I examined RK cornea, radiokeratotomy corneas, the people who had the surgery years earlier, and I looked at it histopathologically, and stroma does not have any power to heal. So those are still relatively open wounds, and that is one reason why lamellar keratoplasty is to be preferred over penetrating keratoplasty, because you maintain some of the global state. All right, now we're gonna
let me just if you guys want to turn on your videos, and we can maybe give the invited panelists a moment to weigh in, because there's a few questions here. I've been reading through them. So I think a good first question is, with these patients, is there any usefulness, if you have these high risk transplant patients, in using channels, peripheral fenestrations, or more advanced designs?
panel?
Anyone can go.
Panel?
I think I'm going to talk before Lynette, because I know she has a lot to say about this, but usually in these situations, I actually use channels a lot. I almost always, I definitely fit large and loose. And I know a lot of people have that philosophy for these patients, because that extra, just, you really want to stay away from suction and any bit of suction, like Vishakha mentioned. So large and loose channels, I just find fenestrating just very, very tedious and cumbersome. I'll let everybody else comment more about that.
To the audience, I'd like to just mention that Dr. DeLoss is a professor at Ann Arbor.
Go Blue!
And we also have need to welcome Lynette Johns, who is now a professor at Massachusetts Eye and Ear. And then we have Dr. William Miller, who is Associate Dean at the Optometry School, Rosenberg, San Antonio in Texas, our neighbor.
I think Bill wanted to say something.
So yeah, I'm going to agree with Karen. I think, fenestrations are problematic, and there are times when I've done fenestrations and then I tried to fill them in with dental wax because it wasn't working for me. And I think, so I think anything you can do to put on some sort of fluting, and then I'm going to ship it off to Lynette, but anything you can do to kind of enhance that and make it loose, so to speak, is the best.
I would say with everybody fitting specialty haptics, for years, people were really migrating to spherical haptics. And now people are doing more alignment, more torics, more quads, more customization. If you are going to be doing all that customization, pull back just to loosen up the fit. If you have a toric lens and you're aligning your steep, you actually pull back on it, you're going to get your tear exchange in, and that's going to loosen up your fit dramatically, provide more oxygenation tears to the surface, and reduce a lot of those suction forces. So hopefully just even doing that, instead of fully refitting to a larger diameter, if you have to do that, you can just change the lens that you're working with now. And the disadvantage is probably a little more fogging from debris, but I'd rather have debris fogging than corneal fogging, which is a significant issue.
Yep.
I think there's another question too, which I think is a good one, which is how many microns, and maybe Loretta, you can take this one. How many microns of corneal thickness do you actually classify as corneal edema?
Well, the classic transplant literature that looks at graft rejection actually calls a 10% increase in corneal thickness as a risk factor for rejection. So when we're talking about edema, I think in these cases, we're talking about clinically visible edema that you can see behind the slit lamp. So that's usually around 20%. But just going back to my first comment, if you are treating a transplant patient with any contact lens, I do think it's our duty to do topography or the slit scanning topography or some form of corneal thickness assessment each time they come in, or at least on an annual basis, because you actually can pick up early rejection and or early kind of endothelial decompensation by that 10% change in thickness over time. But that's not clinically visible.
Right, and just adding into that, you know, I'm pretty strict about always measuring corneal thickness, and I will second that. You definitely notice it on the instrumentation well before a patient's going to become symptomatic, I find.
But are you paying attention to central thickness and or pan-corneal thickness? Or both?
Well, yeah, I mean, that's a great question. I think most of us are looking at central thickness, but I'm working on a study now with some colleagues from an AAOF grant, and we're looking at the regional thickness changes, and we're also looking to see if there are regional thickness changes in comparison to the endothelial cell count in the mid-periphery. So we're actually going to have data on that in a few months. So you can measure the endothelial cell density off-center. The Conan and the NIDEC instruments allow you to do so with fixation targets. You're roughly about 3 millimeters off-center. So you can do that. You can, and I encourage you to do so. Sometimes you'll be amazed at what you see in the periphery, where like the central cell count might be whatever, 800, and it could be extremely lower or higher in the periphery. So we are going to have data on thickness, pachymetry changes from morning to afternoon, and we're going to know what the cell count is in that area. So we'll be able to see regional swelling.
Very cool.
Yeah, I just like to add that the peripheral cornea is like 120 micron thicker, and we are engaged in trying to explain what makes the cornea thicker in the periphery. Amazingly, we don't know. Literature has no information on what makes the cornea thicker in the periphery. We have some data, but we're still working on it.
I
Good.
think you made a good point too earlier, where she was talking about the difficulty sometimes when you're dealing with scarred corneas, whether it's from keratoconus or whether it's from, you know, herpetic disease or microbial keratitis or any of these things. Trying to get a look at what's going on underneath those scars is really problematic with any kind of specular microscopy.
One thing I'd like to ask everybody here is there any type of case where the contact lens, the scleral lens, is contraindicated, maybe other than a active infection? Anything else?
You know, I want to say that even though we might make sclerals look bad in some of these presentations, these people have no other option. I mean, you can't keep any other lens on them. So they may have a clear cornea that's comfortable when they're wearing nothing, but they're also count fingers. So all I do is tell them, look, you can see out of this lens and we can see how it goes. You're on the border of needing a regraft anyway. So we can either regraft now, or we can go with this scleral lens and see how you do. I had one patient that wore hers for 9 years and she did great. One for 3 days. So you can, you have to warn them ahead of time that if we put you in this lens, you are on the border, you're very fragile. We could put you overboard and you may be looking at a regraft. So, and those regrafts are kind of acute, like, cause these people are uncomfortable, at least mine were. So, you know, if it's not a good time of life for them to be making a change where something might go wrong, then it's maybe not a good time to do the scleral lens. But I think you just have to warn them that I'm still gonna proceed, and that's what I do, I still proceed, but let's just be on the lookout for something going wrong. And if it does, you know, you might be looking at a transplant in the near future.
Yeah, that's a good point. And what we need to do is monitor our patients. Karen, you had something?
Well, I was going to say contraindication is if a patient comes in presents with edema, right? So you're not going to fit them with a scleral lens. You know, I typically will send them back to have a regraft or have management. So that's, for me, that's an indication. And exactly what Loretta said, like, these patients don't have another option. It's like Maria was saying last week, I've never taken anyone out of a scleral lens because of IOP concerns. It's the same thing, like, these guys don't have a choice. And I would say when I've sent patients back, they have done They've either regrafted or done a partial graft, desmate, a DMEC, and they can actually sometimes use the same lens too, and it's a power change or something like that. So that's something that you need to think about as well, is that it's exactly, I think Bill said, risk over benefit.
What I would also add is like Fuchs endothelial dystrophy, we always say is a contraindication, but we have patients with keratoconus and Fuchs that present. There's a subset of patients like that. So speaking to what Vishakha said about doing a challenge, you can do a challenge with whatever patient that comes in and just see how their cornea survives and if there's edema that occurs.
Yes, I mean, I think we also have to differentiate between epithelial changes and endothelial changes, because patients can come in with corneal edema, but it's from their epithelium. And I had a patient like that just last week who desperately needed a scleral lens to protect the endothelium. So I did a challenge in office just to see how much worse his corneal edema would become. And it didn't. It didn't become any worse, and his epithelium looked much better as a result.
You make an excellent point too in your presentation, and I borrow this from Clark Chang, who I see is listening in as well, and I would call it the Clark Chang holiday, where he will have patients wear on a reduced wearing schedule in one eye to get to say 4 hours, and then have them wear the lens, another lens, obviously that's fit for the opposing eye, for another 4 hours, and that gets them through an 8-hour workday. So the Clark Chang holiday is a favorite of mine.
All right, I think we are out of time. We reached 1 hour plus a little bit. And I want to thank, again, our sponsors, and I would like to thank our speakers and our panel, and my colleague, Maria Walker. So we call it off here with a reminder that next week we have the third and last IFSLR session, and moderated by Muriel Shornack and Daddy Fadel. And they're gonna focus on an update on oxygen, scleral shape, and new technology.
And I'll comment there, that one is a truly international session because it's got James Wolfshon from the UK, Alejandra Consejo, and David Pinheiro. So they're no one from the US next week. So that's great. It's our real international week. So we hope all of you join us next Saturday, same time, same place. You'll get an email with the links.
Bye-bye and score.
Bye.
Bye, everyone. Thanks so much.